Good evening, Dr. Phil here. Today we'll be discussing on narrow complex arrhythmias. Tachycardias with a narrow QRS complex originate from a site above the AV conduction system. They are also known as supraventricular tachycardias. The diagnosis and management algorithm for tachycardia has been discussed previously in a video, Perioperative Arrhythmias Part 1. Kindly refer to that video for further details. Sinus arrhythmia. Sinus arrhythmia is a normal finding, especially in young people. It is characterized by alternating periods of slow and rapid heart rates. ECG shows sinus rhythm with constant PR interval, irregular spacing of normal complexes associated with respiration, with a rapid rate at end inspiration and a slower rate at end expiration. There is beat-to-beat change in the RR interval. Proposed mechanisms. Inspiration results in activation of pulmonary stretch receptors. This results in inhibition of the cardio-inhibitory center via vagoafferents, and this increases heart rate. Inspiration also causes changes in intrathoracic pressure, stretching of the sinoatrial node. Cardiac accelerations result, and this increases heart rate. Inspiration causes lower intrathoracic pressure. This reduces cardiac output and increases heart rate via the baroreceptor reflex. The mechanism of sinus arrhythmia may involve direct impulse conduction between the medullary respiratory and cardiac neurons. It also may be digoxin induced. Sinus arrhythmia is abolished by atropine. Next is sinus tachycardia. It is the most common arrhythmia occurring in the perioperative period. ECG shows heart rate of more than 100 beats per minute in adults. Sinus rhythm, regular normal P, QRS, and T complexes, a ratio of P to QRS of 1 to 1. Severe sinus tachycardia may be accompanied by ST depression. Causes of sinus tachycardia: increased sympathetic stimulation, increases heart rate by reducing potassium conductance and increasing sodium conductance, increasing slow inward calcium conductance, and increasing the if current. Examples of causes of increased sympathetic stimulation includes as a compensatory mechanism in hypovolemia, shock, anemia, air embolus, pulmonary embolus, heart failure, etc. Fear, anxiety, pain or surgical stimulation, inadequate depth of anesthesia, hypoxemia, hypercapnia, inadequate neuromuscular blockade. Increased metabolic rate can cause sinus tachycardia. Examples include fever, sepsis, pregnancy, hyperthyroidism, and malignant hyperthermia. Certain drugs can cause sinus tachycardia, such as desflurane, sympathomimetic drugs, ketamine, sevoflurane, isoflurane, pancuronium, cocaine, anticholinergics, and atropine. Sinus tachycardia reduces the time available for ventricular filling and coronary blood flow. This may precipitate myocardial ischemia if severe. Management of sinus tachycardia: correct the underlying cause wherever possible. The most common cause of sinus tachycardia is hypovolemia or inadequate anesthetic depth. Treatments of sinus tachycardia are all attempts to decrease heart rate. Beta blockers may be required if the patient is at risk of myocardial ischemia, however used with caution in patients with contraindications for beta blockers, such as heart failure or bronchial asthma. Ivabradine is a sinus nodal blocking agent. It is a treatment option. Sinus bradycardia. ECG shows sinus rhythm with a heart rate of less than 60 beats per minute in adults, normal P, QRS, and T complexes, and a ratio of P to QRS of 1 to 1. Causes of sinus bradycardia includes physiological slowing of heart rate in athletic patients or during sleep, vagostimulation. Vagoactivation at the SA node increases potassium outwards conductance and reduces slow channel sodium and calcium inwards conductance. This reduces the slope of the pacemaker potential and suppresses the if current. Vagostimulation can be caused by carotid sinus massage, Valsalva maneuver, skin incision, stretching or dilation of the anus, cervix, mesentery, or bladder via the Brewer-Lookhart reflex, pulling of the ocular muscles in oculocardiac reflex, and tracheobronchial suctioning. Disease states such as myocardial infarction, sick sinus syndrome, raised intracranial pressure, hypothyroidism, and jaundice can cause sinus bradycardia. Certain drugs such as beta blockers, suxametonium, digoxin, anticholinesterases, propofol, opioids, dexmedetomidine, halotane, and high spinal or epidural anesthesia can cause sinus bradycardia. Hypoxia causes lack of cellular oxygen and cessation of pacemaker activity and may result in sinus bradycardia. Hypoxemia, especially in children, can cause sinus bradycardia. Hypothermia and hyperkalemia are other causes of sinus bradycardia. Hyperkalemia stops pacemaker activity by increasing the outward potassium conductance, and this hyperpolarizes the cell. Hyperkalemia can stop SA nodal firing completely. The algorithm for managing severe bradycardia has been discussed in detail in Perioperative Arrhythmias Part 1. Treatment is unnecessary in a fit patient unless there is hemodynamic compromise, usually when heart rate is less than 40 beats per minute. If the patient is stable, close observation may suffice. In cases with signs of inadequate systemic perfusion, such as hypotension or myocardial infarction, pharmacologic therapy or temporary percutaneous pacing may be necessary. Sinus bradycardia of heart rate less than 40 beats per minute may be poorly tolerated. Treatments of sinus bradycardia are all attempts to increase heart rate, correct the underlying cause, such as by stopping the surgical stimulus. Atropine 0.5 mg is used as first-line therapy for the treatment of bradycardia and may need to be repeated every 3 to 5 minutes up to a total of 3 mg. Alternatives includes glycopyrronium 10 mcg per kg IV, isoproterenol, dopamine, dobutamine, adrenaline, and pacing. Regarding patients on beta blockers, they are resistant to atropine or glycopyrronium. Consider isoprenaline IV infusion, adrenaline IV infusion, or IV glucagon in treating sinus bradycardia secondary to beta blockers. In some cases, bradycardia degenerates into asystole. Cardiopulmonary resuscitation is thus necessary. This can be induced by vagal reflexes. Atrial ectopics are common and benign. ECG shows abnormal P waves usually and arises early in the cardiac cycle. Normal QRS complexes. Very early ectopics may produce abnormal QRS complexes. Ventricular conducting system may still be refractory when the ectopic impulse reaches it. This may be mistaken for a ventricular ectopic beat. Several ectopic sites may give rise to the wandering pacemaker, resulting in differently shaped P waves with differing PR intervals. Causes of atrial ectopics includes impulses arising from abnormal pacemaker sites within the atria, ischemia, hypoxia, light anesthesia, sepsis, shock, and anesthetic drugs. Management. Correct underlying cause. Specific treatment is unnecessary unless atrial tachycardia occurs. Arrhythmias due to reentry occurs when there is an anatomical branching and rejoining of conduction pathways. If an impulse arrives when the first pathway is no longer refractory, it can pass around the circuit repeatedly. Examples include the Wolff-Parkinson-White syndrome, SVT, AF, atrial flutter, and ventricular tachycardia. Wolff-Parkinson-White syndrome. The WPW syndrome is characterized by recurrent supraventricular tachycardias that are triggered by re-entry of impulses through an accessory pathway in the AV node. A congenital accessory connection between the atria and ventricles conducts more rapidly than the AV node but has a longer refractory period. An atrial extrasystole finds the accessory bundle still refractory, but when the impulse passes via the AV node to the ventricles, the accessory bundle has recovered and can conduct the impulse back to the atria. Circular conduction can continue with resultant SVT or atrial fibrillation. ECG shows short PR interval and delta waves before the QRS, wide QRS complexes. In type A WPW syndrome, the accessory bundle is on the left side of the heart. There are positive QRS complexes in lead V1. In type B WPW syndrome, the accessory bundle is on the right side of the heart, and there are negative QRS complexes in the lead V1. Anesthetic management. Avoid increases in sympathetic activity. Avoid drugs that causes tachycardia such as atropine, ketamine, and pancuronium. Avoid drugs that blocks the AV node such as calcium channel blockers, beta blockers, and DIGOXIN, as AV nodal blockade can trigger ventricular fibrillation. Antiarrhythmic drugs should be continued perioperatively. Isoflurane is probably the volatile anesthetic agent of choice as it suppresses accessory pathway conduction. Treatment of arrhythmias follows standard measures, including electrical cardioversion. Management of established cases includes electrophysiological assessment, accessory pathway mapping, long-term prophylactic therapy, for example with flecainide or sotalol, and radiofrequency ablation of the accessory pathway. Paroxysmal supraventricular tachycardia. This is a type of narrow QRS complex tachycardia that is second only to atrial fibrillation as the most prevalent rhythm disturbance in the general population. Mechanism: reentrant tachycardia formation. SVT occurs when impulse transmission in one pathway of the AV conduction system is slowed. A difference in the refractory period for impulse transmission in the abnormal and normal conduction pathways is formed. Impulses traveling down one pathway then travels back through the other pathway. A circular pattern of impulse transmission that is self-sustaining occurs, which involves retrograde transmission of impulses. Retrograde transmission of impulses is triggered by an ectopic atrial impulse in one of the two conduction pathways. Paroxysmal SVT can be classified based on the location of the reentrant pathway. There are 5 types of paroxysmal SVT, and the most common type is AV nodal reentrant tachycardia, which accounts for 50 to 60% of cases of paroxysmal SVT. The reentrant pathway is located in the AV node. Paroxysmal SVT occurs as a result of excessive stimulation of the SA node, atrial excitation outside of the SA node, AV nodal reentry, and reentry through a bypass tract. Paroxysmal SVT may occur in otherwise healthy individuals. It may also be associated with WPW syndrome, lone Ganong-Levin syndrome, hyperthyroidism, excessive consumption of caffeine, nicotine, or alcohol. Clinical features. Onset of paroxysmal SVT is abrupt, with palpitations, dyspnea, dizziness, and polyuria if prolonged. Paroxysmal SVT rarely causes hemodynamic instability in the presence of a structurally normal heart. Regarding the ECG, rhythm is regular, ratio of P to QRS complexes is 1:1, P wave is often hidden in the QRS complex or the T wave. ECG usually shows a narrow complex tachycardia with a rate of 130 to 270 beats per minute. However, broad complex pattern may occur if anterograde conduction occurs down an accessory pathway or when there is bundle branch block. Ischemic changes may be present. AV block may be present, especially when associated with digoxin toxicity. AVNRT typically appears in young adults without structural heart disease, and more than 60% of cases are in women. Management of paroxysmal SVT. Provide oxygen therapy and establish IV cannulation. Synchronized DC cardioversion is recommended for cases of SVT that have adverse signs such as shock, myocardial ischemia, cardiac failure, or syncope. Synchronized DC cardioversion is also recommended when the SVT is refractory to pharmacologic agents. Recommended energy levels for biphasic is 70 to 120 joules and for monophasic is 100 joules. Up to 3 attempts with sedation if required, followed by AMIODARONE 300 mg over 15 minutes and 900 mg over 24 hours. If there are no adverse signs, vagal maneuvers such as carotid sinus massage provides a success rate of 12%, while Sava maneuver has a success rate of 18%. Vagal maneuvers are recommended as the initial attempt to terminate AVNRT. Perform vagal maneuvers with the patient in supine position. Vagal maneuvers may be helpful in differentiating SVT from atrial flutter and fast AF. Adenosine is an endogenous nucleotide that relaxes vascular smooth muscle and slows AV nodal conduction. Adenosine is the drug of choice to terminate AVNRT when vagal maneuvers are ineffective. Up to 90% of atrial tachycardias may be terminated by adenosine. Atrial flutter or atrial fibrillation are not terminated by adenosine. The dose via large peripheral vein is 6 mg via rapid IV injection into a large peripheral vein such as at the cubital fossa, followed by rapid flushing with 20 ml of normal saline. If unsuccessful after 1 to 2 minutes, this may be followed by up to 2 further boluses of 12 mg. If still no effect, abandon adenosine and opt for alternative treatments. If adenosine is administered via central vein, consider halving the dose of adenosine to reduce the risk of asystole. Adenosine is more effective when given by a central vein or into the right atrium. Continuous ECG monitoring during adenosine administration is a must. Onset of action is less than 30 seconds with a duration of effect of 1 to 2 minutes. Examples of contraindications to adenosine includes bronchial asthma, second to third degree heart block, and sick sinus syndrome. Adverse effects are usually well tolerated and last less than 1 minute. Examples includes post-conversion bradycardia, flushing, dyspnea, chest pressure, hypotension, and bronchospasm. Interactions includes with dipyridamole, which blocks adenosine uptake, and theophylline, which blocks adenosine receptors. If the heart rate is still more than 200 beats per minute, amiodarone is an alternative when first-line drugs have failed. The dose is 300 mg IV over 10 to 15 minutes. DIGOXIN, up to 2 IV doses of 0.5 mg over 30 minutes, but avoid in WPW syndrome. DIGOXIN facilitates conduction through the AV accessory pathway in WPW syndrome and may worsen tachycardia. AF in the presence of an accessory pathway may allow rapid conduction which can degenerate into VF. Calcium channel blockers such as verapamil and diltiazem are useful in patients with SVT who relapse following adenosine. However, calcium channel blockers may cause hypotension. Avoid calcium channel blockers with beta blockers. The dose for verapamil is 5 to 10 mg IV slowly over 2 minutes, with a further 5 mg may be given after 10 minutes if required. Beta blockers may be used to treat paroxysmal SVT, such as esmolol, IVI 50 to 200 mcg per kg per minute, or metoprolol 3 to 5 mg over 10 minutes 6 hourly. Overdrive cardiac pacing may be considered, however not in atrial fibrillation. Correct electrolyte abnormalities such as hypokalemia and hypomagnesemia. Electrical ablation can be performed if paroxysmal SVT persists with focal atrial impulses or atrioventricular reentry. Atrial fibrillation. Atrial fibrillation is commonly encountered with 2% in patients less than 65 years old and 9% in patients 65 years old or older. Mechanism: re-entry abnormality in which multiple propagating waves of depolarization are initiated by ectopic foci, most of which originate from the pulmonary veins. Impulses from many different parts of the atria reaches the AV node in quick succession, however only some of which are transmitted. This results in lack of coordinated atrial contraction. Features of atrial fibrillation: irregularly irregular pulse may be associated with a pulse deficit. Ventricular rate depends on the conducting ability of the AV node and is usually rapid. Slow and regular ventricular rate may occur if complete heart block exists. Cardiac output may be reduced. Cardiac failure and hypotension may occur. Atrial contraction contributes up to 30% of normal ventricular filling. AF, particularly fast AF, with or without fast ventricular response, results in reduced ventricular filling, reduced stroke volume and cardiac output. Reduced ventricular compliance from ventricular hypertrophy and mitral stenosis further reduces cardiac output. Myocardial ischemia may occur due to increased heart rate, reduced diastolic time, and hypotension. Intra-atrial thrombus may result in systemic embolism. Thrombi may form within the atria, and this may cause thromboembolic phenomenon. The risk is highest if there is a return to sinus rhythm after 48 hours of AF. In stable AF, the risk of CVA is 4% per year at 75 years old. This risk is halved by anticoagulation. ECG shows heart rate of 350 to 500 atrial beats per minute and 60 to 170 ventricular beats per minute. Irregularly irregular rhythm with absent P waves. Fibrillatory waves may mimic P waves, leading to misdiagnosis. There is absent isoelectric baseline. Normal narrow QRS complexes. Causes of atrial fibrillation includes myocardial ischemia, sepsis, hypertension, hyperthyroidism, autonomic stimulation, hypokalemia, pulmonary embolism, alcohol excess, cardiomyopathy, mitral valve disease, myocarditis, pericarditis, mediastinitis. Post-operative AF may occur in up to 45% of cardiac surgeries, 30% of non-cardiac thoracic surgeries, and 8% of other major surgeries, central venous cannulation, acute hypovolemia, hypomagnesemia, and idiopathic. Treatment of atrial fibrillation. Goals of treatment: to restore sinus rhythm or control the ventricular rate to less than 100 beats per minute. In acute AF, restoration of sinus rhythm is often possible. In long-standing AF, control of the ventricular rate is the usual aim. The ventricular rate should be controlled by appropriate therapy preoperatively. Rapid control of ventricular rate may be required perioperatively. Another treatment goal is prevention of embolic complications. Management of AF based on duration of AF. Correct precipitating factors whenever possible, especially electrolyte disturbances. If the onset is less than 48 hours, synchronize DC cardioversion at 200 Joule. Flecainide is the best drug for converting AF to sinus rhythm. The dose is 2 mg per kg, maximum 150 mg over 30 minutes IV or 300 mg orally. Avoid in patients with ischemic heart disease or heart failure. Cardiac monitoring is required. If the onset of AF is more than 48 hours, aim for rate control unless hemodynamically unstable. Ventricular rates of more than 100 beats per minute should be slowed preoperatively to allow adequate time for ventricular filling and myocardial perfusion. Conversion to sinus rhythm is associated with risk of arterial embolization unless the patient is anticoagulated for at least 3 weeks. Pharmacotherapy. Diltiazem provides satisfactory rate reduction in about 85% of cases of AF. The IV dose is 0.25 mg per kg over 2 minutes, then infuse at 5 to 15 mg per hour. If the heart rate is more than 90 beats per minute after 15 minutes, give a second bolus of 0.35 mg per kg. Oral dose is 120 to 360 mg OD, extended release. Response of diltiazem is superior to IV amiodarone or digoxin. Adverse effects includes hypotension and cardiac depression. Avoid diltiazem in patients with decompensated systolic heart failure. Verapamil 5 to 10 mg IV may be used to slow the ventricular rate in patients unable to take beta blockers. However, avoid verapamil if there is impaired LV function, if there is evidence of myocardial ischemia, or when beta blockers are administered. Beta blockers slow the ventricular rate and provides a satisfactory rate reduction in about 70% of cases of acute AF. Beta blockers are preferred for rate control when AF is associated with hyperadrenergic states. Beta blockers such as esmolol, sotalol, and metoprolol are useful until other drugs have taken effect. Caution in heart failure, bronchial asthma, and when calcium channel blockers are administered. Esmolol is a cardioselective ultra-short-acting beta blocker with a half-life of 9 minutes, and this allows rapid dose titration to the desired effect. The dose is IV 500 mcg per kg bolus, followed by 50 to 200 mcg per kg per minute. Metoprolol is a cardioselective beta blocker. The IV dose is 2.5 to 5 mg over 2 minutes, repeated every 5 to 10 minutes if needed to a total of 3 doses. Oral dose is 25 to 100 mg BD. Amiodarone is an antiarrhythmic with class 1, 2, 3, and 4 antiarrhythmic activity. Advantages includes it prolongs AV node conduction and is effective in acute rate control in AF. It is the preferred agent for rate control in patients with systolic heart failure, as amiodarone causes less cardiac depression compared to diltiazem. Amiodarone is capable of converting acute AF to sinus rhythm in 55 to 95% of cases. Amiodarone helps sustain sinus rhythm once regained and can be combined with digoxin or beta blockers. Disadvantages of amiodarone includes its adverse effects such as hypotension, bradycardia, and elevated liver enzymes, and therefore amiodarone is reserved for cases of AF refractory to other agents. Amiodarone also inhibits digoxin and warfarin metabolism. The dose is 300 mg loading dose, IV via a central vein, followed by 900 mg over 23 hours. Amiodarone may be given peripherally in an emergency, but extravasation is extremely serious. The maximum dose is 2.2 grams over 24 hours. Digoxin may be given if the patient is not already fully loaded with digoxin and should usually be done over 1 to 2 days preoperatively. Rapid IV digitalization may be required when the surgery is urgent, Administer digoxin if serum potassium is normal. IV loading dose is 500 mcg in 100 ml of saline over 20 minutes, repeated at intervals of 4 to 8 hours if necessary, to a total of 1 to 1.5 mg in 24 hours. Lower dose for patients already taking digoxin. Digoxin does not convert AF to sinus rhythm or prevent further episodes of paroxysmal AF. Digoxin levels may be measured with a therapeutic level of 0.8 to 2 mcg per liter. Kindly refer to the specific videos discussing the above-mentioned antiarrhythmics for further details. Management of AF based on hemodynamic stability. For the hemodynamically unstable AF, there is loss of atrial component of ventricular filling as high as 30 to 40%, and this results in reduced cardiac output. Treat with synchronized DC cardioversion, which is indicated when AF is associated with hypotension, pulmonary edema, myocardial ischemia, or when AF is a reentrant rhythm involving an accessory pathway. The dose is synchronized biphasic shocks of 100 to 200 joules. Shocks are synchronized to the peak deflection of the R wave of ventricular depolarization on the ECG to avoid triggering ventricular fibrillation. Use the manufacturer's recommended energy dose. If monophasic, the recommended dose is 200 joules. When immediate cardioversion is required and the duration of AF is more than 48 hours or unknown, anticoagulation with heparin should be started as soon as possible and continued with oral agents for at least 4 weeks. Management of the hemodynamically stable AF. The immediate goal is to reduce AV node conduction and ventricular rate to 80 beats per minute or less using drugs that prolong AV conduction, such as calcium channel blockers, beta blockers, amiodarone, dronedarone, and digoxin. However, these drugs should not be used in cases of atrial fibrillation due to re-entry of impulses through an accessory pathway. Cardioversion can be considered if recent onset AF. Conduct of anesthesia during cardioversion. Position is supine. Duration of cardioversion is 5 to 10 minutes. Preoperatively, if possible, transfer the patient to an anesthetic room with help nearby. Have a physician ready to cardiovert the patient. Serum potassium should be normal. If the onset of atrial fibrillation is more than 24 hours ago and the patient is not anticoagulated, the left atrium should be checked for clots with transesophageal echocardiography prior to cardioversion. If a clot is present, anticoagulate for 4 weeks, then check again. If there are no clots, continue with propofol and secure airway as appropriate. Obtain IV access. Omit digoxin on the day of cardioversion, as digoxin increases the risk of arrhythmias. Amiodarone improves the success of cardioversion to sinus rhythm. Perioperative monitoring includes standard monitors such as ECG, SpO2, and NIBP. Connect the patient to the defibrillator. Synchronize the defibrillator to the R wave. Pre-oxygenate and induce slowly. Maintain airway using face mask with propofol with or without RMA. RSI or ETT if risk of aspiration. SIVO induction is an option. Consider etomidate if hemodynamically unstable. Opioids and muscle relaxants are not usually necessary. Obese patients or patients with awkward airways can be defibrillated in the lateral position. Follow safety guidelines during defibrillation according to ALS protocols. Remove oxygen during shock. Recommended energy level for synchronized cardioversion for atrial fibrillation: biphasic energy 120 to 150 joule, monophasic energy 200 joules. Post-operatively, turn the patient into the recovery position and provide supplemental oxygen. Recover with full monitoring. Kindly refer to the tachycardia management algorithm for further details. Catheter ablation of the AV node or atrial foci where AF originates are reserved for cases intolerant or refractory to other treatment. Anticoagulation is considered if atrial fibrillation has persisted for more than 2 to 3 days, especially prior to cardioversion. Indications for anticoagulation: long-term anticoagulation is recommended for all patients with atrial fibrillation who have either mechanical or bioprosthetic heart valves, rheumatic mitral stenosis, and mitral valve repair. For patients with non-valvular atrial fibrillation, long-term anticoagulation is indicated for patients with either a prior stroke, TIA, or CH2-DS2 VASC score of 2 or more. Oral anticoagulants for non-valvular AF. Options includes warfarin, a vitamin K antagonist, dabigatran, a direct thrombin inhibitor, and factor Xa inhibitors such as rivaroxaban and episaban. For valvular AF, warfarin is recommended for patients with prosthetic heart valves with a target INR of 2 to 3. Atrial flutter or atrial tachycardia. Mechanism: macro reentrant arrhythmia circulating in a specific manner in the right atrium, usually initiated by an atrial ectopic beat. ECG. For atrial flutter, heart rate is 250 to 300 atrial beats per minute with 150 ventricular beats per minute. Rhythm is regular. P and QRS ratio of 2 to 1 or 3 to 1. Atrial flutter with very fast heart rate is usually accompanied by AV block. P waves can sometimes be superimposed on T waves of the preceding beat. There is no flat baseline between P waves, and the typical sawtooth waves can be seen. Carotid sinus massage may slow the ventricular rate enough to reveal rapid flutter waves. QRS are normal. T waves are lost in F waves. Atrial flutter may be paroxysmal or sustained. In atrial tachycardia, the atrial rate is more than 150 beats per minute. P waves can sometimes be superimposed on T waves of the preceding beats. Both can occur with any kind of heart block. Causes are as for atrial fibrillation. Atrial flutter has the same risk of thromboembolism as atrial fibrillation. Management. Treatment of atrial flutter should be started after consideration of the existence of thromboembolism. Atrial flutter and atrial tachycardia are sensitive to synchronized DC cardioversion with nearly 100% conversion rate. The first-line treatment in anesthetized patients with recent onset atrial flutter is synchronized DC cardioversion. Carotid sinus massage and adenosine slows AV conduction and reveals the underlying rhythm where there is any doubt. Other drug treatment is as for atrial fibrillation. Rapid atrial pacing is an option. Avoid DIGOXIN as it may convert atrial flutter into atrial fibrillation. Multifocal atrial tachycardia is irregular supraventricular tachycardia with 3 or more P-wave morphologies with irregular atrial activation pattern. Predisposing factors includes elderly, chronic lung disease, pulmonary hypertension, magnesium depletion, potassium depletion, theophylline toxicity, and coronary artery disease. Management. Correct hypomagnesemia and hypokalemia. IV magnesium sulfate 2 grams over 15 minutes then 6 grams over 6 hours can be given when serum magnesium is normal, as serum magnesium can be normal despite total body magnesium depletion. Metoprolol has 89% success rate in slowing or converting MAT to sinus rhythm, while verapamil has a 44% success rate. Sick sinus syndrome is sinus node dysfunction with intermittent loss of P waves or sinus arrest, causing episodes of symptomatic bradycardia. Sick sinus syndrome may coexist with AV nodal disease. AV block, atrial tachycardia, atrial flutter, and atrial fibrillation may occur concurrently with sick sinus syndrome. Causes includes congenital, OH, ischemic heart disease. Sick sinus syndrome may be precipitated by anesthesia and result in refractory bradycardia or even asystole. Symptoms: the patient may be asymptomatic, have dizziness or syncope. Sick sinus syndrome is a major cause of sudden death in children and young adults. Management: permanent pacing is required if symptomatic. These are my references. Thank you.